Hi, everybody. It's Michelle Andrews again with the American Heart Association. I am representing them as an instructor for basic life support, advanced cardiac life support, and pediatric advanced life support. A few years ago, I posted the advanced cardiac life support tutorial online, really in an effort to help those of you who were uncomfortable with all of the knowledge, needed a little extra study guide, and I just really wanted to share that with you. I enjoy teaching, and if you remember, if you have not watched it, definitely go watch the ACLS tutorial that I put out a few years back. I believe it was 2021. But one of the things that we spent the most time on with advanced cardiac life support were the rhythms. Because I found that through my teaching, a lot of my students just really had a hard time identifying rhythms. And so that's just an area that I wanted to tackle and maybe help you with those. PALS is a little different, and it's a little scary, I think, for a lot of people because we don't work, not everyone works with the pediatric population. And if you don't work with them, just having your PALS because you're required to have it is sometimes difficult to achieve. And that is my passion for putting this tutorial package together and offering this to you for a fee, of course. And if you're interested in obtaining the full package, not just the YouTube, I have created about 7 different PDFs full, jam-packed full of information, but well organized as to what American Heart Association recommends, and all the accurate information for PALS. And so we're just going to go ahead and jump in and get started first by telling you what we're going to review. Okay, we're going to start off reviewing basically where American Heart Association recommends we start off, and that is with the assessments of our pediatric population. Assessing our patient is an ongoing process the whole time they're with us. So I'm going to share that with you. I'm going to break it down. There are great mnemonics to help you remember how to do the assessments. And those assessments are going to provide you with some information that's crucial to being able to intervene and help that pediatric patient. And so I'm very excited to share that. Then from there, we're going to go into looking at specifically some different respiratory illnesses that the pediatric population presents with. And then we're also going to look at shock. That is huge for a pediatric population. It's probably one of the most common diagnoses for the pediatric population, and easy for them to go into is different forms of shock. So we're going to go over those, and then we're also going to go over some rhythm recognition and how to treat that rhythm, right? Is it a shockable rhythm? Is it not a shockable rhythm? If it is a shockable rhythm, is it necessarily defibrillator shock? Is it a cardioversion shock? Is it just simply pacing? So these are the things that we're going to review. And I have some little extra tidbits as well that I've thrown in there that American Heart Association makes a point to share with us in their book, and that's called The H's and the T's. They also go into some high team dynamics that's extremely helpful in having a nice clean code should you need to go in that direction, right? And then we'll just close with that. But I want to let you know that I'm also going to be starting to share some brief videos as well regarding our pediatric population, because I think that if I share different scenarios with you and we discuss those together, it's just really going to help you become a better clinician in the acute care setting. If you're in home care taking care of patients, same thing. I just think that this is needed. I don't see a lot of it on YouTube, and I'm excited to get that information out there. So you're going to see that starting to come across often. I appreciate all of your comments that you'll hopefully be giving back, good or bad. I want to hear them, because if I can improve, I want to improve. You can always reach me if you're interested in purchasing this full package of the PALS tutorial online with all the PDFs, and then access to me personally through a closed group on Facebook. So if you're interested in that, you can contact me through my email. It's allinclusivesafetytraining@gmail.com. Okay? And I'm Michelle with 1L Andrews. Okay? So you can just let me know a little bit about who you are, what you do, and why you're interested in this package. All right? Because the certifications are every 2 years. We have to have them. And especially with so many healthcare providers traveling now, PALS is just par for the course, isn't it? They want BLS, but they want ACLS, they want PALS, and they want NRP as well. So American Heart Association does not provide the NRP, but we do provide the other three, and I can help you with all three of those. So definitely email me. My name again, Michelle Andrews, email allinclusivesafetytraining@gmail.com. Okay, so let's go ahead and get started. I promised you that we're going to start with that assessment, right? So American Heart Association, if you were to look at the PALS book as a whole, it's overwhelming. I broke it down for you. I have typed up above and beyond really what you need, but highlighted what you really need to know, okay, for the PALS course. All right, so we're just going to go ahead and jump right in. It starts with what American Heart Association calls the systemic approach, right? And they create just a little triangle called the Pediatric Assessment Triangle. And we're going to go ahead and draw that on the board for those of you who have not purchased this PDF package. You're not going to have that right in front of you. And so I'll put just a few things on the board so you can jot them down if you're one of those ones that's just happen to come across this and, you want to be able to jot down just a little bit of information. I certainly understand that. And so, this isn't for everyone, but for those that it is, you'll have the package in front of you with the PDFs. And for those that you don't, let's go ahead and turn this camera around now. I apologize for the halo over my head. That is actually my ceiling fan and my light, and it's providing some nice cool air here in Florida. Okay, so we're going to turn it around so you can see my board. And there you go. And so it starts out with what I had shared with you just a second ago, the pediatric assessment triangle, right? And so they call it PA, and I am a terrible writer. Legibility was not what I was given stars for in elementary school. All right, so that's the pediatric assessment triangle. It's pretty, I know, but up here, we're going to erase just that little piece right there. Because right here, I want to go ahead and write evaluate. Down here, we're going to write identify. And then over here, we're going to write and I'm just going to stop there. That's intervene. Now, let's talk about what this represents. This as a whole represents an ongoing, it's the denominator. This is ongoing, right? This never stops throughout the stay of the pediatric patient with us. We're constantly evaluating, number one. We are constantly identifying what the problem is, number two. And number three, we are constantly intervening, right? And then we're right back up to re-evaluating. So I think that's something that you really need to grasp. The light bulb needs to come off right there. Right there. Evaluate, identify, intervene, evaluate, identify, intervene. We are constantly doing it after each and every effort that we make to try and help the pediatric population for the diagnoses that they came in with. Okay? So that is going to stay on the board. We'll go ahead and erase the PAT because I feel like it's just a little confusing, but I want you to know that this was called the Pediatric Assessment Triangle. And so under that, we basically start our assessment, okay? So the first assessment starts out with our initial assessment. Makes sense, right? So we're just going to go ahead and write initial assessment. In the initial assessment, basically right here is where we start. It's what we can see, it's what we can hear upon entering the room where our patient is located. And American Heart gave us a great mnemonic to be able to do our initial assessment, right? They gave us the A, B, and the C. The A standing for the appearance, right? So appearance, you can write that right beside there. If you have the PDFs, you already have it written there. So, in the appearance, are they reactive? How's their muscle tone? What can you see? What can you hear? Are they crying? How are they positioned when you walk in? What can you see? Are they retracting? Are they nasal flaring? What's their color? Do a quick assessment, the color of their peripheral extremities to the trunk. So what can you see? What can you hear? So we look at appearance, okay? Appearance. Then we're going to look at their breathing. What can we see? What can we hear as far as breathing goes? In that breathing, American Heart recommends that we look at, again, are they retracting? What is their respiratory rate? Is it too high? Is it too slow? What type of position are they in? Are they in the sniffing position? Are they cuddled up in a comfortable layover position with mom and dad? Someone holding them kind of in a tripod position and they're leaning against mom and dad. We've seen that a million times. So that's their breathing and then their circulation, right? circulation is huge in PALS. And you're going to hear me say it over and over and over again, because circulation is a primary problem with our pediatric population. So with circulation, we're going to be looking at, all kinds of things. My goodness, we can look at color. We can look at, are they mottled? Are they pale? Are they blue? Are they, cyanotic around the mouth? Circulation, what's their pulse? Palpate that pulse. But remember, the initial assessment is really just about what you can see and what you can hear, okay? And then we're going to move right on to the primary assessment, okay? So the very next thing is going to be the primary assessment. I just love red, so we're going to stick with the red. It's working for me. Primary assessment, okay? So in the primary assessment, American Heart has a mnemonic for us there too, and that's just simply A, B, C, D, and E. Okay, so primary assessments A, B, C, D, E. A stands for airway. You guessed it, airway. Is it patent? That's in your primary assessment. This is when you're going to start getting closer to the patient, right? So airway, is it patent? Do they have an advanced airway in? Was it put in out in the field and they came in with it? Be prepared for a possible oral airway. And remember, you only put an oral airway in if they're, unresponsive. Right? Because we don't want them gagging, and it's just very uncomfortable, and it's not appropriate to put one in unless they are not conscious. Are we going to need to be prepared to suction that airway? And if so, are you familiar with what can happen? What are some of our side effects that can happen when we suction that airway? Right? One that just comes to my mind, right? Where they can Brady down. So be prepared when you suction, if you have to. And then, finally in that airway, do they need a chin lift? If they need that to make a patent airway, it's a possibility. We're going to go over the anatomy of the baby in the upper airway, and you'll see why it's very possible that just simply by repositioning their head tilt chin lift, it'll open up the airway, okay? Because I'll just go ahead and go over that right now, but essentially, a child's whole upper airway is really different than it is for an adult. I feel like I want to share that to you on my baby Rudy when we get her out. So we'll go ahead and wait then for that. Let's go ahead then and go to what this mnemonic stands for. It's airway, as we discussed. So I want you to go ahead and write that down if you don't have the PDF package, if you're not part of this team, and you're just taking a sneak peek. Breathing is the next assessment skill that we're going to use. Breathing, is it regular? Is it labored? Is it fast, slow, with nasal flaring? Breathing, how's their I-to-E ratio upon inspiration and expiration, right? How is that breathing? Do you hear rales? Do you hear wheezing? Do you hear rhonchi, stridor, grunting, snoring? So this is all in your breathing. All right, then you go into your circulation. Circulation again, guys. Circulation again. This is beyond what you can see and hear. We're now looking at circulation. Is the chest rising and falling? Is there an increased effort? How's their capillary refill? Huge. Prolonged expiration again. can fall right into circulation, guys, because why? Because, let me turn this around. Because if they have prolonged expiration, when I auscultate their lungs and they have a prolonged expiration time, think of a balloon. I blow it up. I let a little bit of air out. I blow it up again. Even more. Let a little bit of air out. Blow it up again. And let just a little bit of air out. What have I got now? Air trapping. Air trapping. And that air trapping and all that pressure from that air trapping is going to cause some cardiac issues, isn't it? Don't think of that. But air trapping. So we want to look at their expiratory phase, right? Is it lengthened? So, and then they go into, looking at, and you'll hear me say this a couple of times, looking at their peripheral compared to their trunk. Is it two different colors? That shows a perfusion problem. That shows a circulation problem, right? And then something you can see real quick when you are doing your assessment is babies and the young pediatric population, they get blue around the lips, cyanotic, real quick. So along with cap refill, we can do that real quick as well. That all has to do with circulation, okay? So we're going to turn back around and finish our mnemonic. We have D and E. So D simply stands for disability. Disability. So let's go ahead and write that in there. Giving you time to write it down as well, YouTube audience. My dog is howling. He doesn't like to be away from mommy. Okay, so with disability, we're looking really at their level of consciousness and a mnemonic under disability, another mnemonic. But these mnemonics, guys, American Heart is so helpful. Whoopsie doopsie. They're so helpful with these mnemonics. There might seem to be a lot of them, but really they're helpful. You remember in school, AVPU, alert, voice, alert, voice, I'm drawing a blank, pain, and unresponsiveness. I'm sorry, I was drawing a blank there because I'm listening to my dog howl. And he sings beautifully. So alert is my patient under disability alert. How's their voice? What's their pain level? And are they unresponsive? AVPU, what is that score? That falls under disability. And finally, is the big one, I think, is exposure. Exposure, guys, is a head-to-toe assessment. It's a head-to-toe assessment. It's really the involved assessment out of your primary assessment. When we're looking at exposure, we're looking at, the pulse ox check, labs, specifically looking at, God forbid that an ABG is warranted for poor baby, but if it was, we're looking at hemoglobin, CO2, pH. We're looking at blood glucose because, American Heart says anything less than 40 for, the infant, and anything less than 60 is considered, hypoglycemic. So look at that blood sugar because it's so crucial to neurostatus, to our cardiac issues. They can actually have a stroke if it's not, repaired quickly. And then, look, eyesight. I always think of eyesight because I wear contacts and glasses and, I've worn them since I was a child. I often wonder, was I somehow, my blood sugar not checked when I was born? Under exposure after labs, look at, are they pink? Do they have bruising on their skin? Do they have trauma on their skin? Do they have injuries to their body? broken bone? Do they have a rash? Are they warm? Are they cold? What is their temperature, right? Pupillary response. We want to look at the size of the pupil and its reaction to light symmetry. So we want to look at it, right and left, right? So the symmetry of that is crucial, right? Because if that is affected, we've got what? Neuro problems? Maybe, right? And so, again, exposure's a head to toe assessment. So we're looking at, not only injuries, not only reaction to light, but we're looking at that heart rate, we're looking at that rhythm, and finally we're looking at the possibility of infections. Because remember, we said that we're going to look at their labs. So it's a quick way to look and see, is it possible that they've got some sort of an infection going on, right? So exposure's huge. It's the biggest part of that primary assessment. So what have we covered so far? We have covered that we have a pediatric assessment triangle of evaluate, identify the problem, and intervene with the problem. And it's a constant, right? It never stops. Every 3 to 5 minutes. Whenever we do something, we are then evaluating, identifying, and intervening. Okay? Don't want you to forget that. I'll say it a million times. It's a light bulb that should have gone off and stay on at all times. So you did your initial assessment using your ABCs. We looked at our airway. We looked at, is it patent? Does it have an advanced airway in there? Do they need an advanced airway? Ooh, that's something we're going to talk about. And then breathing and circulation. And then we went into our primary assessment using the mnemonic ABCDE. We were looking at airway, breathing, circulation, disability, and exposure. Exposure being the big one, the head to toe assessment. That's where you do your head to toe assessment, right? From head to toe. Are there any injuries? Do they look suspicious? Right? They're bruising. Is there skin tears? Are there broken bones? Is there an unexplained rash? Are they warm? Are they cold? What's the difference in color of skin around the mouth to the trunk to the periphery? Pupils. This is where you're going to do your eye exam. Okay, and all of this information you're going to share with your with the patient's doctor, and it's so helpful for them, right? Because it shortens the amount of time that they have to assess. They're really counting on you. The physicians really count on you, if that's your patient, to do a thorough assessment. And so that's going to take us to that final assessment, which is called the secondary assessment. So let's switch and write that up on the board. Okay. So our final assessment, as my dog Nico continues to sing along in praise, is the secondary assessment. Whoopsie. It's not my red, is it? And it's almost Valentine's Day, 2023. So red seems appropriate. Secondary assessment is our final assessment. So we'll put number 3 beside that. That's our final assessment. And the mnemonic for this is a little different from ABCDE. It's actually called sample. I just love that American Heart has made this so easy for us. So when we're looking at sample, what does that stand for? Well, we're really looking at information in the secondary assessment that comes from the caregiver to us. So, your pediatric population can't necessarily remember what they had to eat last night. They don't know what over the counter meds they might take or supplements they might take. And so we really count on the caregiver to give us this sample assessment. And so we're looking at signs. Signs of what? Right? Signs, symptoms. What can you see? Example, are they tacky? Are they short of breath? Do they have a decreased appetite? You can ask the caregiver that. A stands for allergies. Allergies, guys. If you take this online through the American Heart Association, for one, it's very expensive, but I will tell you, I did it once to see what it's like. And allergies, I always forgot to ask about my allergies, and they failed me for it every time. I had to go back and start over. It was kind of funny. So allergies are including things that, you're not necessarily thinking of, but how about meds? Food allergies, animal allergies, household product allergies, environmental allergies. So those are all the allergies that we're speaking of. And then M stands for medications. Go ahead and write that down if you have not purchased this package. Medications. All right. Medications. So we're not just talking about their prescribed medications, guys. We're talking about, over-the-counter meds, right? And they might have an allergy to some of them. And we don't know that yet. They're still young. Supplements is another allergy they could have, or medication they could be taking. And then P stands for past. Past what? Well, how about past everything? Because their life is so short so far. So past injuries, past medical history, past hospitalizations, hopefully there weren't many. Past immunizations, huge. Huge. Because some people don't believe in those, do they? All right. How about past coughing at night? Yeah. They cough every night. Every night they go to bed, they cough. Or they cough every time they try to swallow something thin. Ooh, that's important. So again, information on the secondary assessment is coming from the caregiver, and they're saying to you, in the past, this is what I've noticed. All right, then L stands for the last meal and time of last meal, last administration of the meal, last, right? Not past, but last. And so in the last, we're looking at, the last medication and administration, and what was it? And that comes from the caregiver. Now, mom may not know this, but, baby Rudy is 2 years old, and she got up at 9:30 last night. Mom's saying she didn't eat dinner last night, but dad chimes in and says, oh, baby was crying at 9:30, and I did make her a grilled cheese. So there you go. So the caregiver's information is just a wealth of information for us. And finally, you've got events. What kind of events? The events that led up to this. The events that led up to this admission. The events that led up to this admission. Guys, what am I talking about? I want a thorough timeline. I want a thorough timeline from that caregiver to my ears so that I can write that down and that be information that I can share with the physician that's going to be the treating physician. Or the physician that might have to come in and do a consult. All right. So there is, going to turn you around. There's your assessments. And that was pretty fast. We can go kind of fast because you have it on your PDF printout because you have partaken of this course. All right. Those of you who have not, I will remind you that you're more than welcome to email me at allinclusivesafetytraining@gmail.com and ask to, purchase this package. And by doing so, did you know that all the tests that American Heart does are open book or open notes, if you will? And I have everything here that's important out of that book already typed up for you. All right, we're going to look now, after learning about our initial, our primary, and our secondary assessment. We're now going to look at high team dynamics. I'd just like to take a brief moment to go over that review because it's important to achieve specific performance metrics. When we're doing chest compressions, we're looking at frequency, we're looking at depth, we're looking at, is it a quality CPR situation that we're in? If it's not, don't be scared to say so. Don't be scared to say, hey, Steve, are you getting tired? Do you want to switch compressing? If not, you've got to get down a little deeper. Why? Well, because of this right here. First, I'll remind you that American Heart, as with ACLS, they do not want us taking any more than 10 seconds off of that patient's chest. What would take us off the chest, Michelle? Lots of things. You'd be surprised. Until you're in that code, you don't realize it. But placing that board underneath that patient takes time. Switching compressors takes time. Intubation, they may need you to stop compressions for a few seconds, takes time, right? So charging the defibrillator, we're now continuing chest compressions until that RN has said everyone clear, and we indicate that we're clear. Also, too, delivering the breaths. Sometimes, we're supposed to deliver the breaths asynchronously, but, as they come up on the chest is when, I, as a respiratory therapist, would always attempt to deliver my breaths. I see that I'm using Steve as an example. Hi, Steve, if you're out there. But as Steve comes up on the chest, I squeeze the ambu bag and give that breath, okay? So that's how I typically do it. But high team dynamics, as American Heart Association says, they basically just want to make sure we remember no more than 10 seconds off the chest. How deep do we want to go when we're doing our chest compressions? About 1/3 the depth of the chest cavity. For infants and children, about 1/3 the depth of the chest cavity. Guys, we could have an 11-year-old that weighs 220 pounds. And I know 1/3 the depth of the average child is 2 inches, but for that 12-year-old maybe that weighs on 220 pounds, we might have to go a little deeper. So American Heart changed that to 1/3 the depth of the chest cavity. That's going to be the answer on the test. And that is a question on the test, or it has been in the past. I will put it that way. How fast do we want to go? 100 to 120 times a minute, but I'm not a big fan of saying that. I'm a big fan of staying alive, staying alive. The Bee Gees, guys, that's the tempo we're looking for, right? That's the tempo that we're looking for. Now, initially, your adrenaline's up, you've started your compressions, you hear the snap, the crackle, the pop on those children. You won't hear it so much on the babies. They're still pliable, I say, but you've heard that snap, crackle, pop with that 12-year-old, and now, it's kind of flexible, and so you're going down 1/3 the depth of the chest cage, blood's rushing out of the left side of the pump, and then it's refilling when you recoil all the way back up. It's refilling on the right side of the pump, and you're going a little fast because you just started, your adrenaline's up, you're nervous. How about clean it up within 10 seconds? Clean it up. If you know you're going too fast, you're going to be counting. I don't hear a lot of counting. I'd love to hear a lot of counting. I love clean codes. But if you're going to count, count quietly if you must. And then go ahead and, staying alive, staying alive. And 7, 8, 27, 28, 29, 30. How about this? Cycle 2, 1, 2, 3, 4, 5, 6, 27, 28, 29, 30. Cycle 3, 1, 2, 3, 4, 27, 28, 29, 30. Cycle 4, 1, 2, 3, 7, 8, 29, 30. Cycle 5, what did that just tell the doctor, the nurse practitioner, periodontist, whomever is running that code? What did that just tell them when you said cycle 5? It said, ooh, Steve's on his last set of 30 compressions. And so we need to get Lisa ready to take over. Isn't that great? So I do recommend letting them know what cycle you're on. Think about being out in the field. You found a child down in the aisle of Walmart. It could happen. It could happen. They could choke at Panera Bread on a piece of that crusty bread. I can't believe parents give their children that. It's so thick. I just would not have done that. My children are grown, and it's so... Anyway, I made other mistakes. At any point, they could fall unresponsive and stop breathing after that choking incident. And so CPR has been started. And so saying what cycle you're on after calling 911, they're still listening in. And they hear you say cycle 5. And so now they're able to relay to the EMS dispatcher that, hey, this victim has been down at least 2 minutes because he's finished up his last set of 5, right? 30 compressions, 5 sets. So we know that takes about 2 minutes. So we know our victim's been down for about 2 minutes. So it really does come full circle. Also, too, is the breaths. We're giving breaths to babies and children. We are giving breaths. I think that I was concerned when I would have students come to me and say, oh, we don't get breaths anymore. We don't get breaths, we don't get breaths, we don't get breaths. Oh, yeah, we do. Oh, but we do. We do. So for baby Rudy, she's getting breaths. And if there's 2 rescuers, she's getting 15 compressions to 2 breaths. And that's a question that will be on your test. Okay? That's a freebie for you. And then if it's 1 rescue, it's 30 compressions to 2 breaths. So we are giving breaths. Okay? All right. And so knowledge sharing is something else that will be on your test. And basically what that is as a team, and this is just a great segue to go ahead and bring in the PDF that you have that looks a little something like this. Down the road we go. If you look on there, I have in black bold letters, CPR team. And the CPR team is basically your 2 CPR rotators, your 2 respiratory therapists that are at the head of the bed, making sure that the airway remains patent, suctioning if we must, intubating if we must, monitoring that CO2 if we must, and if we're ordered to do so, getting that ABG if we're ordered to do so. So there's a lot that respiratory does that's extremely helpful. Then you have your RN on IV or IO. What's an IO? Better know it. It's on the test. Interosseous. Interosseous. It looks like... I'm going to take a drink of my water. It looks like a hot glue gun. A mini one. and it's a drill. And it drills access into the sternum, the humeral head, the tibia, and the medial malleolus. Okay? So, medial malleolus is what you're going to forget. On the test, if they say, patient was in a motor vehicle accident, the humeral head, the tibia were crushed, that's a contraindication to putting an IO in. And we're doing CPR using the sternum. What other site could we use for an IO? Because Lauren wasn't able to get IV access. Medial malleolus is going to be your answer. Okay? Then you've got your RN who's on documentation, and God love her. She's documenting names, dates, times, what was done, actions. And she's also in communication with that doctor. It's been 2 minutes, doc. It's been 2 minutes, doc. Here's what we've done, doc. Here's what we've tried. Who's in charge of this patient? Doctor, it's Ann Fang. I don't even know if there is an Ann Fang. Watch, there probably is. But it's Ann. There's an RN on defibrillation, right? And that is really important as well. So we want to know that she understands what she's doing. We want to know that she understands how to receive those doctor's orders. That, for defibrillation, it's 2 joules per kilogram, 4 joules per kilogram, 6 joules per kilogram, and 8 joules per kilogram. She needs to know that, but the doctor's going to order that, right? So it's kind of like 2, 4, 6, 8 joules per kilogram is how we deliver for our pediatric population. And so she'll need to be able to place these pads on the patient depending on their age, right? So baby is on the front and one on the back. Turning that baby over and putting this on the back. It's going to take time, isn't it? There's some of your 10 seconds. Children, right? We're going to put one in the upper left-hand region. Or right-hand region, I'm sorry. And if they are, for some reason, having contusion or something there, you might have to go around that. And then on the other side, we put the other one. You see the red arrow pointing right down there underneath that left breast, okay? And so she knows how to place those. She understands that she needs to analyze that rhythm for that doctor to be able to see. So she might say, everyone clear. We're going to analyze, and everyone indicates I'm clear. And then once the doctor has seen the rhythm, way less than 10 seconds, he said, resume CPR. And so we resume CPR. And so then he might say, okay, well, the patient's in VFib. And so he says, okay, charge at 4 joules per kilogram. And so she charges, and while she's charging, everyone continues CPR. And then when she's ready to shock, she says, I'm shocking, everyone clear. I'm shocking on 3, 2, 1. Everyone indicates they're clear. And she says, boom, shock delivered. Okay? So there's that nurse. And then you might have sometimes a pharmacist in that code team. You might have, even in a rapid response, they might show up. Some hospitals, it's really cool. They have code teams, right? So for that day, they get the code phone. And whenever there's a code, no matter where it is in the hospital, they show up for it. There's even a chaplain in some of these. So it's really clean and organized. And then after the code, we really want to share what happened. How did it go? Where can we improve? Where did we do good? Okay, so I wanted to go over that high team dynamics with you. That quick review. Pulse checks is another thing that can take time. The doctor might want one. All right, and so naturally, we're always going to use the carotid pulse when we're in a lethal code situation like that. But when we're just average checking a baby's pulse, just remember that for infants, we use the brachial. That will be a question on the test. And for children, we use the radial. Okay? Don't forget that. Write that down. Okay, so we have learned about the systemic approach. We've reviewed some really good high team dynamics, right? And so we also went over the CPR team and what it looks like. So now we're going to jump in, and if you have this PDF of respiratory illnesses out, I'm actually going to just say it's respiratory illnesses labeled black bold at the top. We're going to review those 4 respiratory illnesses, and that is upper airway, lower airway, lung tissue disease, and then disordered controlled breathing. All right? Most upper airway is just what it says. It's an upper airway condition, isn't it? Right? So what are we looking at? We're probably looking at croup. We're looking at epiglottitis. We're looking at possibly aspiration. How about an anaphylactic reaction? Swelling. Very real. Very real. So signs, auscultate them, but here's what you're going to hear in the upper airway, and this will be a question on the test, and that is stridor. Stridor equals upper airway. Stridor equals upper airway. Stridor equals upper airway, so does barking cough. In American Heart Association, I kind of snicker a little bit because the answer's really hidden in the question so many times, right? Patient is blah, 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 and they fill it with all this nonsense information, and then they say barking, cough, and stridor, and you're like, upper airway, upper airway illness. So, we want to look at increased respiratory rate. We want to look at all respiratory parameters, all hemodynamic parameters. And then we want to go ahead and auscultate to see if they do have stridor. Are they starting to deteriorate? Because if they are, can we intubate them? I don't know. If they're swollen, maybe not. Might have to consider a trach. Are they drooling? Are they in an easy to breathe appearance? Kind of like that tripod sniffing position, it's easier to breathe like this. So that's something that you'll see with upper airway. Lower airway is bronchitis and asthma. All right, bronchitis and asthma. What am I going to hear with that when I auscultate them? Wheezing, probably a lengthened expiratory phase. Yes, in fact, a prolonged expiratory phase. Remember, we talked about that earlier, the balloon and the air trapping. We don't want that. So we really want to fix them up. And by the way, going back to upper airway, how can I fix that upper airway constriction, racemic epi? And that's a question on the test. Lower airway, bronchodilator, right? Wheezing, bronchodilator. I just don't like it when doctors order bronchodilators for an ingrown toenail or something, But I'm finding actually that albuterol nebulizers are useful for more things than you think. We want to look at their respiratory parameters. We want to keep track of their hemodynamic parameters. And so we want to also auscultate them and consider using a nebulizer, or even if it's advanced asthma, and they're just really puffing and huffing, and they're air trapping big time, and they're just suffocating, and they're irritable. They just can't breathe. They're starting, maybe heart rate starting to drop. We might really want to consider, after we got that IV access, give them some kind of a prednisone, steroid, something, right? Might want to do that. Lung tissue, respiratory illness. We're looking at pneumonia there. Pneumonia. And what else are we looking at? Not adult respiratory distress syndrome, but respiratory distress syndrome, where the lung tissue has become stiff. Because, the lungs should be like balloons, right? Or like a rubber band, real elasticy, right? Every time you breathe, it's kind of like that. But with respiratory distress syndrome, it's like, it's stiff. And when it's stiff, your alveoli aren't exchanging CO2 and oxygen very well, are they? So, lung tissue disease is really a problem. Pneumonia is the first thing I think of when I think of a lung tissue disease. And so, American Heart says you could probably going to have decreased air movement. And I actually put that in my notes. Decreased air movement. In other words, decreased to absent. Sometimes I can't hear anything. So they might even be grunting. What's that mean? They're grunting. God bless them. This makes me so sad. Rails. You might hear rails. They might initially have an increased respiratory rate as they're trying to get the air in, and then they just poop out. Because, see, children are like rubber bands. They're stretchy, right? And they can compensate, and then they'll compensate again, and then they'll compensate again. But eventually they're going to poop out. That is why it is so important to remember, evaluate, identify, intervene, evaluate, identify, intervene. Constant. It's a constant. It's a constant. We are constantly evaluating, identifying, and intervening. Constantly. Every time we do something. And then finally, disordered control of breathing. What is that? This is sad. If you've got a respiratory illness and it's described as being in the category of disordered control of breathing, it's a neurological problem. What's their ICP? Right? Take a peek at these. Doctor's going to be looking at all neurological signs. He's going to get a neuro consult, no doubt. So, auscultate's going to probably be normal to decreased air movement. There's going to be some poor muscle tone there if this has been let go. The respiratory rate may be kind of shallow, right? Because doesn't the neuro control our rate of breathing? Yes, it does. And so treat the problem first is what American Heart recommends. And keep that position comfortable for breathing. I don't care. If they want to stand on their head, let them stand on their head. I'm kidding, but keep it comfortable. All right? Treat the problem first. Remember, this is where I want to talk about the anatomy of the child. The pediatric population as a whole. I speak for them all. The larynx, and I'm going to read this verbatim. The larynx in infant and children can be funnel-shaped. Think of a funnel. You guys out there that put that oil in the, got a funnel in there. Wow, can you imagine that's how you're shaped in your larynx, right? It's funnel shaped. It's shorter than adults. And the tongue or epiglottis are larger than adults. So now we got like double the problem, right? The cricoid below the vocal cords is narrow. All this is an obstructive issue. All that's an obstructive issue. So imagine getting an anaphylactic issue problem on top of that anatomy. We got problems. I also go through, and I'm not going to share it on YouTube because I just want to leave you really wanting more, and this is more, and this will be on the test. So those of you who have purchased this package through all-inclusive safety training at gmail.com, you've received 7 different ready to go oxygen modalities, and basically they're important. When to use them, when it's appropriate, how much, what do they look like, how many liters, all of that information is on there. I left nothing out. Okay, that's your respiratory illnesses. Finally, we have circulatory or shock circulatory failure, because shock is circulatory failure. And so I label this PDF in black bold letters, shock circulatory failure. And so it's an inadequate delivery of oxygen to meet the adequate need of the tissues. The tissues require a certain amount of O2. And for some reason, we have an inadequate delivery of O2 to those tissues. And that will place the patient in shock. All right? So let's go through them. It can be present with increased or decreased cardiac output, can be progressive. You need to know this. It can be progressive. Doesn't happen all of a sudden. It can be progressive. And the patient may deteriorate rapidly as well. So, something I wrote in there that I want to say to you, those of you on YouTube as well. Never, ever, ever use a dextrose fluids for shock. Never. All right? American Heart made sure. Big bold letters. Lots of exclamation points. No. Okay. What are our types of shock? There are 4 of them. Hypovolemic is the first one and the most common. Right? It's a loss of vomiting or loss of volume. Take your pick. Not peeing, not drinking, diarrhea, vomiting, again, inadequate fluids, burns. Don't think of that much, do we? Burns. All right, so they're going to be tacky. They're going to have poor perfusion. Their level of consciousness would deteriorate when they're left alone, and then all of a sudden they're back awake when you come back or pinch them. They respond to pain. Their blood pressure, many increase and then decrease as the shock progresses. So the blood pressure might be okay at first, but it's going to decrease as the shock progresses. It's let go. We've got to come up with the fact that they're in hypovolemic shock, and we've got to treat that. So to treat it, we want to keep a track of their hemodynamics, right? Respiratory hemodynamics, or cardiac parameters, respiratory parameters. We want to look at their blood sugar. We want to look at their systolic blood pressure. And I have a wonderful little trick to know if you're in the area of normal for systolic, because American Heart came up with this. So I'm going to go ahead and erase our secondary assessment on the board. Now I'm going to keep up our pediatric assessment triangle because, guys, we're still using that, aren't we? Remember, turning you around. It's a constant. We're still doing that throughout this whole extravaganza of this patient, right? So, but what is that systolic little tidbit you were going to give me, Michelle? Well, it's 70 plus parentheses. 2 times their age in years equals, these are coming later, systolic. I'll back up so you can see it. Now, American Heart is clear to say that that does not mean that's the normal systolic that it should be for that child's age and years. For example, this child might be 3 years old. 2 times 3 is 6 plus 70 is 76 for systolic. That doesn't mean that's where he or she should be. Okay? They actually say in the book, if you really want a more accurate where they should be, put a 90 there. That's probably where they should be. But that's not on the test. That's in the book. If you want to see if their blood pressure is on the line, this is your formula right here. Okay? Turning you around. See, the dog is still, he's still going. He's so precious. I could just spend an hour talking about him. Okay, so essentially that is, you know, our blood pressure tidbit tool. You need to know it, know it, know it, know it, know it, know it, know it. Know it as we start going through these short videos that I promised you. Because we're going to ask questions sometimes, and you'll be able to pull that out and use it to kind of answer the question as we go along. So what are we going to do about the hypovolemic shock? How can we treat it? Good question. Great question. Fluid resuscitation. An American Heart recommends 20 milliliters per kilogram, all right, over 5 to 10 minutes. What are we going to use? Better question. Not dextrose, right? No, no, no. Normosaline or lactate ringers, okay? Distributive shock is the next one. What is that? It's just what it says. Distributive shock is septic shock, right? It's all over the body. It's distributive. It's distributed, right? It releases toxins to cause vasodilation and portrays a fever and a rash. And it can control, obviously, it's going to happen over the course of hours, okay? More water. I'm hypovolemically challenged. I've had a cold 3 times since Christmas. So's my doctor. I went and saw him the other day. So, big fat face here is called prednisone. It's one of those drugs you just hate to love. Okay. So, anaphylactic shock is also another distributive shock example of. So, they ingested an allergic food, bee sting, etc. They're exhibiting swelling of the airway. Oh my goodness, with that anatomy already being what it is, it's a possibility. Should they crash and burn, we're going to have to go here, isn't it? But again, babies are bouncy little rubber bands. And so I think it hurts us more than it does them. It saves their lives. And God bless their little souls. That's what we're after. We want to save their lives and give them as much time on this earth as we can. Patient can pass or go into arrest within minutes as well. You need to know that because they put that in bold letters in the book. It tells me it's going to be on the test. So, all right, how are we going to treat them? Septic, American Heart recommends a prophylactic antibiotic within the first hour of care. A prophylactic antibiotic within the first hour of care. Dealing with sepsis, guys, that's poison, you know? Yeah. And then 10 to 20 milliliters per kilogram of fluid bolus. Vasodilative drugs if child does not respond to that IV fluid bolus. We're going to do a vasodilative drug. Remember, we're still evaluating, identifying, and intervening every time we do something. So we're going to know if it's not being effective, we're going to go ahead and deliver that vasodilative drug. The doctor knows this, but isn't it nice if the nurse knows this or the respiratory therapist knows this? Sure is. He counts on us to help. That's why it's a team. We're going to use that same blood pressure little tidbit, right? To see if they're on the line, right? They need to be a little higher. In distributive shock, fluid resuscitation, as I said, will be with normal saline or lactate ringers. Signs, really, of distributive shock is inadequate blood flow to some tissues, but too much to others. It's associated with vasodilation and some cap leak or decreased cardiac function. That's so scary. Tachy, poor perfusion, warm, flushed skin, brisk cap refill, right? So monitor the vitals of the child. As children compensate, then they crash and burn. We've said this, and I'm going to keep saying it. And it's going to be on your test. I'm going to skip cardiogenic shock and go to obstructive for those of you who are participating in this event because I want to save cardiogenic. You'll see why. Obstructive shock, cardiac output is impaired by physical obstruction to blood flow in, out of the heart. So with, obstructive shock, the cardiac output is obstructed. And you nurses who work the NICU, God bless you. You already know about obstructive shock. You've probably seen it a lot. And God bless you. So what is it? Caused by air, fluid, blood clots, tension pneumo, cardiac tamponade, PE, congenital heart defects. This is what my nurses know. Congenital heart defects, like ductal dependent lesions. So how are we going to treat it? Fluids and vasodilators. We're going to treat that underlying cause, aren't we? Especially ductal dependent lesions. We're going to treat the underlying cause. We're going to monitor their hemodynamics, their respiratory parameters. We're going to keep an EKG rhythm going. Labs, reevaluate every 5 minutes because it's so hard to distinguish between hypovolemic, distributive, and obstructive shock. It's just so hard to distinguish between them because they're all kind of due to cardiac output. I promised you we'd go back to cardiogenic shock. Inadequate perfusion caused by poor myocardial function. That's a big one. That's why it's not hard to distinguish between this one. It's caused by poor myocardial function. Congenital heart disease, myocarditis, cardiomyopathy. The signs, though they might be tachy, then they'll start to decrease. Increased vascular resistance and severe vasoconstriction with decreased cardiac output. Pulmonary congestion. What are we going to auscultate, do you think, with pulmonary congestion? Rails. Definitely rails. We're going to monitor the hemodynamics, respiratory parameters. Arrhythmias are going to be real at that point. Sepsis can develop, drug toxicity, direct myocardial injury. We need an expert consultation. We need a pediatric cardiac doc, and they are amazing individuals. Blood pressure, if systolic, decreased below 70. In children, and below 60 in infants. Bolus 5 to 10 milliliters per kilogram of isotonic crystalloid saline or lactate ringer over, here's the key, 10 to 20 minutes. That's very slow. Very slow. Okay? We're going to give them some oxygen. We're going to keep that EKG going. We want IV, IO access ready to roll. BLS ready. Be BLS ready all the time when a child is in shock, right? And check that hyper or hypoglycemic as well as other labs. And then reevaluate in 5 minutes. Guys, I cannot say enough that we're going to reevaluate every 5 minutes. And then we're going to intervene or identify the problem and intervene. Because every time we've done something, we might identify a different problem that makes it closer to the point where we have repaired this child's problem. What did we learn? We learned 4 things. We learned respiratory illnesses, and we learned 4 types of shock for children. And you've got that all on your PDF printout. I really went above and beyond on that. I'm not tooting my horn. I'm tooting the horn of all the students that have tooted my horn for me. And I so appreciate that. I really, 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 really appreciate that. Because it's why I'm doing what I'm doing right now. It's given me the confidence to get on here and say, look, there's people out there that can't get to me, that want to know, that want this information, that want this material, and I'm going to give it to them. Now, we're going to close learning some EKG rhythms. Now, if you're not someone who can read your EKG rhythms off the fly, take my ACLS course. It's online. Email me at allinclusivesafetytraining@gmail.com and just say ACLS, please, because I spend most of my time teaching you to read those rhythms. If you're a new grad, if you're going to be a traveling nurse, traveling respiratory therapist, learn those rhythms. Learn those rhythms. You want to be the smartest person in the room, and you need to know how to treat those rhythms. So I go over them, really breaking them down in ACLS. Okay, now I'm going to switch this around. Hello. Here we go. So we've got letter A here, and we have a normal sinus rhythm. We know that because we have a clear-cut P right here. We have a clear-cut QRS, and we have a clear-cut T, and nothing is distorted or abnormal or not within the normal limits. So that's a normal sinus rhythm. Don't really need to do much for that patient except monitor that patient. And then we have a sinus tachycardia. This patient here, I don't know. This patient came in with a fever, had a little bit of vomiting, but not much. And so, we're just going to monitor this patient of sinus tachycardia, but I want you to be able to recognize it, okay? You can clearly see that there's, little P, little Q, nice, beautiful QRS, nice little T here. Then you have sinus arrhythmia. Why is that a sinus arrhythmia? Because it just fell down. How about because it's got an irregular rhythm to it? So it's, like beep, 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 beep. So we've all palpated the pulse of someone who has, an irregular heartbeat. And so you need to know what that's going to be looking like on record. D is, a narrow complex tachycardia, right? I always say if you have a tachycardia without a P, you probably have SVT. And in this case, a narrow complex tachycardia, that's exactly what we have. SVT cutoff for children is 220. SVT cutoff for infants is 160. I'm sorry, did I say that backwards? Yes. Infants 220, children 160. All right. VTAC, wide complex tachycardia. Man, I could talk to you so much about VTAC. But that puts them in that area here, SVT and wide complex. If this patient right here is symptomatic with a pulse, what are we going to give them? They fall in the tachycardia algorithm. So, doctor might order, I'm just thinking 0.1 milligrams per kiloliter of adenosine. I mean, we're going to try bearing down first. This one here, I don't think it's going to work. This one, there's a chance. Bearing down might work. And if they're not able to follow directions, you can take a cloth, put it in ice water, and then lay it on their face, and that will do the same thing as bearing down, in case you didn't know. Just a little tidbit for you. If the 0.1 milligram, 0.10 milligrams per kilogram of adenosine didn't work with a max up to 6, then we can go to 0.2, okay? If we had to go to cardioversion because they continue to deteriorate, or we never got to the adenosine because they deteriorated so quickly and we just had to forego the adenosine and waste it, then we're going to cardiovert at 0.05 to 1 joule per kilogram. Okay, that's 0.05 to 1 joule per kilogram. That's cardioversion. All right. And then here we have, now I want to ask a question real quick. Back to E. If this patient's symptomatic with no pulse, that's what makes VTAC so tricky. She's bipolar, folks. If she has no pulse, she's pulseless VTAC. Oh my goodness, you're kidding. You just took this all in a whole new direction. That's right. That's right. Pulseless VTAC gets shocked. It gets defibrillated. Is that true? Yes, it is. So how much, we're going to use that VFib pulseless VTAC algorithm that you have on your printout right here. You see it there. CPR shock, CPR shock, CPR epi, CPR shock. Now that is your algorithm for VFib pulseless VTAC if she was pulseless. And so in that case, the epi amount that we would give is 0.01 milligrams per kilogram. And then for using the amio, if we get to that point, the doctor orders amio. We're going to use 0.5 milligrams per kilogram for amiodarone. If the doctor wanted to use lidocaine, it's 1 milligram per kilogram of lidocaine. Okay? The joules, as we discussed earlier, for defibrillation are 2 joules per kilogram, 2, 4, 6, 8. Follow that little, I don't know, memory helper. I can't think of the right word, but that's just extremely helpful. Right here we have SVT, which we're going to go ahead and deliver some adenosine to. And how much are we going to give in that first dose? Yes. 0.10 milligrams per kilogram and a max of 6 milligrams. And then we're going to give 0.2 milligrams per kilogram. Okay? So that was F. Then we're going to go to G. We got a sinus Brady. You can see that. I don't like a sinus Brady on a baby. Not at all. But on a primary Brady, American Heart recommends 0.01 milligrams per kilogram every 3 to 5 minutes, okay? And so with a max of 0.5 milligrams per kilogram. This is used really for that AV block. You know what an AV block is? Stop. I know. I'm a great artist. SA. Node to AV node to bundle of His to Purkinje fibers. Right? And what connects them is our little conduction wire, if you will. We have an AV block. Beep, 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 beep. And so for that, sorry, I dropped something. For that, American Heart says, for a AV block, we're going to go ahead and use the atropine. All right. It looks like for a secondary Brady, if it was a secondary Brady, we're going to use 0.01 milligrams of epi. All right. So write that down. Secondary Brady, that will be on the test. Secondary Brady, 0.01 milligrams per kilogram of epi. All right, so there's your numbers. There's your pharmacology. That was our part. Here's a complete heart block. How do I know? Because I'm looking at the relationship between the P and the QRS and the T. And I notice that it's different. If I have my protractor out, the P to the QRS is different in every single segment. In every single segment. Come take my ACLS class. You will know this was a 3rd degree heart block before I ever told you. There's an agonal rhythm going down to asystole. That's not good. That makes me sad. VFib gets shocked, don't they? But we start out with CPR. Then we shock using the 2, 4, 6, 8 joules. And then we go to epi, 0.01. Then we go to amiodarone, which we said was 0.5 milligrams per kilogram of amiodarone. All right. We've got polymorphic VTAC here with a run of torsades, in case you were wondering what that was. We treat polymorphic VTAC pretty much the same as we do VFib, because they're getting ready to go into VFib. Here's VFib with a shock delivered, so you can see what that looks like. Do we stop and check for a pulse after the shock? No, we don't. Not anymore. We go right back to CPR. Remember that. Question on the test. And finally, asystole with some artifact. So I was able to share with you really the most important things that you need to know regarding your PALS, and the knowledge that you have now is wonderful. I would like to invite you once again to contact me. Give me some feedback if you're on YouTube. It helps me, whether it's positive or negative. It really helps. So if you want to contact me personally and partake in having this packet sent to you, you can do that through all-inclusive safety training at gmail.com. Michelle Andrews signing out. Go get 'em, guys. Bye-bye.